Hello everyone. Today I'm going to present the fourth case of obstetrics. This is a case study on hyperemesis gravidarum. Let's learn about this condition through a case. Our patient is a 28-year-old female who is referred by her general practitioner with persistent vomiting at 7 weeks gestation. She is in her second pregnancy, having had a normal vaginal delivery 3 years ago. She is now vomiting up to 10 times in 24 hours, and she is not able to tolerate any food for 3 days and can only drink small amounts of water. She saw her general practitioner a week ago who prescribed chlorperazine suppositories, but these only lasted for a few days. She feels very weak in herself and is unable to care for her son now. On direct questioning, she has upper abdominal pain that is constant, sharp, and burning. She has not opened her bowels for 5 days, and she is passing small amounts of dark urine infrequently, but there is no dysuria or hematuria, and there has been no vaginal bleeding. There is no other medical or gynecological history of note except that she suffered persistent vomiting in her first pregnancy, requiring 2 overnight admissions. So the patient has faced similar complaints in the past during her first pregnancy also, and now she has a very severe case in her second pregnancy where she is constipated for 5 days and she is drinking very less amount of water and is not able to have any food. Upon further examination, she is apyrexial. Her lying blood pressure is 115 by 68 and standing blood pressure is 98 by 55. Her blood pressure is slightly low, as we can see in these values. Her heart rate is 96 per minute and the mucous membranes appear dry. This could be due to the excessive dehydration that is seen in the patient. Abdominal examination reveals tenderness in the epigastrium but no lower abdominal tenderness. And the uterus is not palpable abdominally, which means the uterus is normal and there is no tenderness seen in the uterus. So lab tests were performed in this patient. Her hemoglobin mean cell volume is normal. WBC and platelets are also normal. Her sodium is normal, but it is very close to the lower range. Her potassium is low and her urea is high. Her creatinine, alanine transaminase, and alkaline phosphatase is normal. Gamma glutamyl transaminase, bilirubin, and albumin are all normal. Pregnancy test was performed and it was positive, which confirms that the patient is indeed pregnant. And on urine analysis, protein was negative, blood negative, nitrites was negative, leukocytes was negative. Only ketones were found to be positive, and glucose is also not found. So the diagnosis, the woman is suffering from hyperemesis gravidarum. This affects only less than 2% of pregnancies, although more than 50% of women report some nausea or vomiting when pregnant. Differential diagnosis of vomiting in early pregnancy is urinary tract infection, gastroenteritis, thyrotoxicosis, and hepatitis. Here, all the differential diagnosis is ruled down in this patient because the urine analysis was normal except for the positive ketones. So UTI is not present in this patient. The patient does not have any GI symptoms except for constipation, which could be due to improper diet and low water intake. So the patient is not suffering from gastroenteritis. Thyrotoxicosis is also not the case because her thyroid levels are also normal and all her liver function tests are normal. So hepatitis is not a diagnosis in this patient. About this condition, so what exactly is hyperemesis gravidarum? It is a pregnancy complication that is characterized by severe nausea, vomiting, weight loss, and possible dehydration. This patient was also suffering from all these symptoms. The exact causes of hyperemesis gravidarum are unknown. Risk factors include the first pregnancy, multiple pregnancy, obesity, prior or family history of hyperemesis gravidarum, and trophoblastic disorder. Multiple pregnancy involves the presence of twins or triplets or multiple babies in mammals, especially. And trophoblastic disorder is a presence of tumor during pregnancy. HG has been technically defined as more than 3 episodes of vomiting. Our patient has more than 10 episodes of vomiting per day, such that weight loss of 5% or 3 kilograms has occurred and ketones are present in the urine. So, our patient had ketones in her urine and she had more than 3 episodes of vomiting along with some weight loss. So, we can define that the patient was suffering from hyperemesis gravidarum. Treatment includes drinking fluids and a bland diet. Recommendations may include electrolyte replacement drinks, thiamine, and a higher protein diet. There are some complications of hyperemesis gravidarum which involves Wernicke's encephalopathy, Korsakoff syndrome, hematemesis, and psychological abnormalities. How to manage this condition in this patient? So, firstly, fluids can be administered. 3 to 4 liter of normal saline should be infused per day. In this patient, dextrose solutions are contraindicated as they may precipitate Wernicke's encephalopathy, and also because the woman is hyponatremic and needs normal saline. So the patient's sodium level was pretty borderline, 131. So she needs normal saline rather than dextrose, and Wernicke's encephalopathy is a condition which falls under the complications of hyperemesis gravidarum, and it is caused mainly due to B1 deficiency, which is thiamine deficiency. Wernicke's encephalopathy are biochemical lesions that form in the CNS due to vitamin B1 deficiency. And the next thing that we can administer the patient is potassium, since her potassium was low. So excessive vomiting generally leads to hypokalemia, and potassium chloride should be administered with the normal saline according to the serum electrolyte results. The patient could be given some antiemetics. First-line antiemetics include cyclizine, which is antihistamine, metoclopramide, dopamine antagonist, or prochlorperazine. In severe cases, ondansetron or domperidone may be effective. There is no evidence of teratogenicity in humans from any of these regimens. Thiamine and folic acid should be given to the patient. Vitamin B1 can prevent Wernicke's encephalopathy or the irreversible Korsakoff syndrome. Korsakoff syndrome is also an irreversible disorder that is caused due to vitamin B1 deficiency, and usually the patient suffers from both these disorders at the same time, which is known as Wernicke-Korsakoff syndrome. And Korsakoff syndrome has symptoms, sign and symptoms, which are amnesia, confabulation, impaired learning ability. Further, patient can be given antacids for epigastric pain. There was some tenderness found in the examination in her epigastrium, so antacids can be given for relieving this pain or to reduce the acid secretion. Total parenteral nutrition, these are pharmaceutical products which involve nutritional products, and this is mainly used to bypass the normal eating and digestion mechanism in a patient. It is directly given parenterally and it helps in increasing the nutrition in the patient. And thromboembolic stockings and heparin. Women with hyperemesis are at risk of thrombosis from pregnancy, immobility, and dehydration, and should be considered for low molecular weight heparin regime as well as TEDs. Further monitoring should be done in the patient. Daily monitoring should be carried out with weight measurement and urine analysis for ketones and renal and liver function. So that's it for today's session. Thank you for watching and please share this video. Thank you.